Hey everybody. Today we're going over chest tubes. So yeah, this is a little bit of a different class just because it's not a disease process, but actually just like a piece of equipment that we're going over. But it's a piece of equipment that a lot of students and nurses sometimes have a lot of anxiety and stress around managing and they're a little unsure of. So we're going to talk about it and hopefully make it so that's not the case for y'all. So first off, when we think about a chest tube, this is what we're usually thinking of. The tube itself actually is not this thing though. The tube itself is, if you see, this piece that's kind of tracking behind the little drainage collection device. So it's coming here from the patient. So this goes up to the patient, comes down, and it's draining all the stuff out of them, right? And it's going into here. And there's some other pieces to this. We're going to talk about them. I might kind of flip back and forth between slides to talk about them. But this is the drainage collection device, right? And this is what gives some people a lot of anxiety is how we manage this because we have to do some specific things with each of these different chambers. So I'm going to mention it now, but I'm going to go over it again as well. So there's going to be some repetition here, but it's because, the best way to learn something is to repeat it, to hear it or to do it enough times. So yeah, so this just going left to right, this is the suction control chamber. This is where the suction is being applied. This, you can't see it because this tube is actually in the way in this picture. This is called the water seal chamber, right? And it's forming, like it says in the name, a water seal. It's like forming a seal over the opening that the chest tube has created that's sealed off with water, right? And this is just the drainage collection chamber. So this is where the drainage comes and it's being sucked. Now, it's not always going to look like this. It's going to fill up to here, and then it'll spill over and fill up to here, and so on. So you see this much drainage. This would mean it's time to change out the system, which we'll get into as well. But yeah. So first off, what are they? Again, it's a chest tube. It's a tube that goes into your chest. So, all right, I'll see y'all next video. Just kidding. It's a drain that's inserted into the chest, usually in one of two places, the pleural space or the mediastinum, right? One of those two places. The purpose of it is to drain air, blood, or any other drainage that might be in the chest cavity, right? So we use them in the pleural space to do things like resolve pneumothoraxes, right? So pneumothoraxes are collapsed lungs. Oftentimes, there's a lot of things that can cause it, but one of the ways is, if you have like a punctured injury or something in your chest, it makes the pleural space become like lose the vacuum that it has. So basically, your pleural space is under negative pressure, and that's what allows your lungs to re-expand as you breathe, right? So when there's a puncture or something, that actually causes that vacuum to stop. And so now they're not able to expand. And so it causes the lung to collapse because now there's not like the negative pressure that allows it to fill back up. So to help resolve that, we got to pull all the air and maybe other drainage and stuff that's trapped in the pleural space that's letting the vacuum not kind of restore itself, or the negative pressure, I should say. Um, Pleural effusion, that's when you get fluid in the pleural space, which could also actually cause a collapsed lung, but it's just a more specific thing where you have fluid or bacteria or something, like an empyema. An empyema is like a fancy way of saying a little pocket of pus that develops that's putting pressure on the lung. So then the other thing we can use it as is just as a straight drain, which it's draining in these examples, um, but it's draining to help restore function to the lung. If it's in the pleural space, it's because yeah, we got to free up the space around the lung. Like there's not the pressure isn't equalized in the right way. And it could be because there's air, it could be that there's drainage or something else. As a drain in the mediastinum, this is usually used after surgery, usually after CABGs, so coronary artery bypass grafts. And it's to get blood and drainage out of the space after surgery so that we can prevent complications like what's called cardiac tamponade, which is basically you have too much stuff surrounding the heart. And so it like puts pressure on it, right? Because the heart can't beat effectively because it's being squished by all the blood and drainage, right? So if it's in the pleural space, you're going to see that the chest tube is actually coming out of the side of the patient, right? Kind of like the side of their chest. If it's in the mediastinum, it's going to be coming usually in the midline of the anterior chest kind of like under or near where the sternum is, right? Because again, after in a CABG, if it's an open CABG, meaning that they do an open chest surgery, they're probably cutting the sternum to get to the heart. But again, not every CABG is done that way. There's some that are done other ways. So the main reason this is important is because how we look at the drainage collection chamber and how we manage it changes a little bit depending on where it is and what the purpose is. So, okay, first off, when the chest tube is inserted, one, we don't do this. This is done by a physician, but we might help a little bit. One, it's a sterile procedure, so we might help them maintain sterility, gather sterile supplies, hand them supplies, things like that. We also are going to potentially help position them in the position the patient needs to be in, depending on if it's going in the pleural space or the mediastinum, pre-medicate them, so giving them pain meds or maybe even anti-anxiety medications beforehand, reassuring the patient, and then also helping to set up and prep the drainage system so that once it's in, we can immediately connect them. So again, this is the drainage collection system. This is two examples of the same thing, again, the same picture as before. One difference is this one doesn't have a suction control chamber. It is a suction control valve, but it works effectively the same. It's just that the suction can be controlled directly from the drainage collection chamber, right? In this case, you would hook this up to the wall suction that's available in the patient's room, right? So again, this is the suction control chamber. This is the water seal chamber. This is the drainage collection chamber. Here, this is the suction control device. This is the water seal chamber. And this is the drainage collection chamber, right? For the purposes of any tests or anything we do or in lab, we're just going to assume that they have all the three chambers, that they don't have a suction control device, but they have its own chamber. Where you work, that might be different, but all the hospitals locally, as far as I'm aware, have drainage collection devices that have a suction control chamber on it. The other thing is that there's a lot less to know if it just has one of these. Not a lot less, it's a little bit less, but it's easier probably if it has one of these. Again, the difference is this just controls the amount of suction that's being applied versus the amount of suction that's being applied on a suction with one that has a suction control chamber. That would actually be controlled at the wall suction, so away from the actual drainage collection device. So just real quick, and I'll mention this on the upcoming slides, but the suction control chamber, this is where the suction's happening. So we want this to be gentle, continuous bubbling. So a little bloop, 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 just gentle, continuous bubbling here is good. The water seal chamber, we want no bubbles at all. If it's in the pleural space, we might see what's called tidling. And that's the water levels maybe here, but we notice it goes up and down as they breathe in and out. Excuse me, I'm getting over a cold, so I still have a little bit of a cough. So we might see tidling here as they breathe in and out if it's in the pleural space. That's okay. The tidling might stop or might start to resolve as the pneumothorax resolves, and that's also okay. So if we see tidling, that's okay. If we don't, that's also not necessarily bad or anything. And then the drainage collection chamber, it collects drainage. And so as it fills up, we mark it. So we don't change this every time we end a shift. We mark how much drainage has been. So as this much drainage has been on our shift, at the end we put a piece of tape and we mark it with the date and time. And then this much after the next shift, we mark it with date and time. And then once it gets full, that's when we swap out the whole system. We don't empty it, we just swap out the system. And again, this is the same thing. So again, suction control chamber. Here's a water seal chamber. Here's our drainage collection chamber. And then this would be the tube going to the patient. This would be going to our wall suction. So the suction control chamber, again, it's either wet or dry. If you recall, this would be dry, this would be wet, because this is actually filled with water. This isn't, right? So we just use the little dial. With the wet suction control chamber, though, we fill it up with water. So one of the things we do is we actually fill it up with water. That water is going to evaporate as the suction's applied because it's applying suction and it's causing air to bubble up, and so it causes evaporation. And that's okay. A little bit will evaporate, but it's why we want continuous, gentle bubbling, because the more vigorous the bubbling is, um, the more often the water is going to evaporate, and so we don't want that. It can also cause a change in how much suction is being applied. So you want the amount to be continuous, gentle bubbling. If it's like super vigorous, or some word, like that, like way too aggressive bubbling, um, then you would want to turn the suction down some. So turn the level down. Or if it was intermittent bubbling, just like it was very seldom bubbling or not bubbling at all, and we want it to suction, we would have to turn the suction up. The water seal chamber. So this is forming an underwater seal on the tubing, right? Again, the water level might tidle on inspiration and expiration. That's the titling I mentioned. If there's no titling, that just means a pneumothorax has been resolved. If there is titling, that means it's in the pleural space and we're resolving the pneumothorax and the pressure issue. Intermittent bubbling in the water seal chamber is okay, but I'm saying that kind of in a bad way. You see how I'm like, it's okay. We don't really like it, but it's okay. An occasional bubble, I mean, a super occasional, means that air is being pulled out of the pleural space. So at every once in a while bubble, like very seldom. Continuous bubbling in the water seal chamber is bad. That means there's an air leak. That means somewhere in this tubing, right, there is a leak. And so instead of the suction being applied into the pleural space, it's being applied, somewhere else. So we need to check it for kinks or for cracks or something like that, or that the tube is maybe even out of place, or that the dressing isn't secure, something like that. So we don't want bubbling in the water seal chamber. Again, maybe an occasional one, but we don't want any bubbling in it. And then the drainage collection chamber, this fills up with drainage, hence the name. I mentioned we mark it with tape or a pin or something to show us how much has been on our shift. Once it gets filled up, we change the whole system. And then we just document the amount, the color, the characteristics, whether it's serous sanguineous, all that stuff. So our nursing care. You want to keep this below the level of the patient. So again, think about like your Foley catheters or your other drains. You want to keep it below the level of the patient. You want to keep the tubing free of any kink so that it can drain freely. You might get a bit of discrepancy depending on where you work on this one, but generally you want to keep it taped to the floor so that the system doesn't fall over. Because if it falls over, it can crack and break, and that can cause an air leak. Obviously, if it's broken. So depending on where you work, they might tell you not to tape them to the floor. But again, generally the advice is you should tape them, but they might tell you not to. Just check with your policies and procedures at the hospital you work at. You want to have some way to make sure it doesn't fall over easily because they're easy to knock into in the patient's room. And then you just need to monitor the chambers, monitor the patient, monitor that the suction is going appropriately. One thing I'll mention is not everybody um, who has a chest tube is getting suction, right? It could just be a straight drain. Or if somebody says it's to water seal, that just means we're just keeping it sealed off, that there's a chest tube and we're just sealing it off. Maybe it was under suction before and now the problem's resolved. So now we're just doing like a trial release. Like let's just leave it to water seal. If we need to suction again, we'll turn it back on. Um, but not everybody needs suction. If there's no suctioning, that means there won't be any bubbling in the water or in the suction control chamber. And again, there shouldn't be any bubbling or tidling or anything in the water seal chamber because there's no suction being applied. So some problems that could happen in what we do. If the tubing becomes dislodged from the patient, so let's say the tube gets pulled out of the patient's chest, we want to cover it with a sterile dressing and tape it on 3 sides and call the physician immediately because that means that we need to get a new tube in, but we need to keep it closed because, again, it's an open portal into their pleural space and it can cause them to have a pneumothorax if they didn't already have one. Or if it's in their mediastinum, it's just an open portal of entry into their chest, right? If the drainage system breaks, we replace the system. In the meantime, you take the end of the tube. So the chest tube is still in, but the drainage collection that it's attached to is broken. You want to take that chest tube and put it under 1 inch of sterile water. So basically you fill up like a cup or a container of some kind with sterile water, and you're going to like put the end of the tube in it. Effectively, what you're doing is you're creating a water seal. That's what the water seal chamber does. It's just, a more official version of doing that. This is kind of like, your uncle's way of doing it. It's a jerry-rigged water seal chamber. So it's just temporary until we get it fixed. If the drainage system gets full, we replace it. So what you ideally want to do is you want to have an extra system in the rooms that as the one gets filled, you just swap them out real quick. You don't have to go get one. When you swap them, you just clamp the tube. You turn the suction off and everything, clamp the tube, disconnect it from the drainage collection chamber, connect it to the new one, unclamp the tube, turn the suction back on. Do not milk or strip the tube. So that means, like, if you imagine this finger is the tube, milking or stripping it would mean I take my clamps or something and I like squeeze it, trying to pull stuff through. We don't do that. Some older physicians and nurses and stuff might do it because they were taught to do it, but you really shouldn't. And the reason is by milking or stripping the tube, you're more likely to cause an air leak because you're going to potentially crack the tube. So don't do it. Similarly, do not clamp the tube unless you're following an order or policy from a physician. So you might clamp the tube again as like a trial release kind of thing. They turn off the suction and they put it to water seal, and they say, okay, clamp it for a little bit because they're going to remove it soon. But generally, or you clamp it between changing out your drainage system, but otherwise you really shouldn't be clamping them. So again, unless you have a specific reason for doing so, don't be clamping the tube because it's preventing the drainage. And then the last thing is just when they're removed. So when they're removed, again, you might have orders to leave it clamped or to water sealed beforehand. That's okay. You just do that, and then you remove it when you're told to. Again, you don't do the removal. It would be a physician, but you might help out, right? So again, gathering supplies for them, probably giving them some medication again before because it might be painful. When we remove it, usually you want them in a semi-Fowler's position. You want to have the person perform what's called a Valsalva maneuver. So that's when you take a deep breath in and you bear down. So imagine you're trying to push the air out, but you close your mouth. So you're like trying to push the air out, but you won't let yourself. Or like, not to be crass, but if you're sitting on the commode and you're trying to go to the bathroom and it's not easy and you're bearing down real hard, like you're trying to, push out a bowel movement, that's can cause you to perform a Valsalva maneuver. And so usually we don't want people to do this because it can actually cause them to pass out. And it's sometimes when people pass out on the commode, it's because they are straining and they accidentally give themselves a Valsalva maneuver. But we wanted to do it in this case because it helps keep any air from escaping or going in to the pleural space while they're removing it. So you have them, take a deep breath in and then bear down as we remove it, or as the physician removes it, and then they pull it, then they put the dressing over it. Once the dressing's in place and everything's good, we might monitor it and everything. But yeah, otherwise it's pretty much it. And then following that, they might need a chest x-ray afterwards or, an in-depth respiratory assessment to evaluate them. They also might be getting these things as they have the chest tube in. So it would just be evaluating like, yeah, is it okay? Um, so yeah, I know it's kind of a weird class a little bit. It's just a quick rundown of the equipment. And again, depending on where you work and depending on the manufacturer, some little things here and there might be different. But I know these are pieces of equipment that a lot of nurses and students sometimes struggle with, or they're like scared of, they're intimidated by them because again, it's a tube going into a person's chest, and they know there should be bubbling some places, but not other places, and they forget which one's which, and they're like, "Oh, I see bubbling here, but is that good bubbling or bad bubbling?" So hopefully this helps clarify things. Again, there's also, hopefully helping prepare you for the NCLEX because there might be NCLEX questions about chest tubes and, here's a bubbling here. Is that good, bad, any different? So it's just something to remember as you're studying for the NCLEX. Just be, when it asks you about chest tubes, usually it's going to be asking you about what does bubbling in one tube or another mean, or one chamber or another mean. That might not be the only thing you're asked, but that's kind of a classic NCLEX type question. But again, hopefully this helps as you're preparing for the exams, as you're preparing for NCLEX, and hopefully as you're working on the floor as a nurse, so that you're not as intimidated by these. And yeah, I think that's it. So yeah, hopefully this was useful. If not, then hopefully another video will be useful. See ya.